Director of Diversity and Inclusion here at Clara Maass Medical Center. We're thrilled today to bring to you a conversation with Dr. Robert L. Johnson. As many of you know, he's the first person in the country to simultaneously lead two medical schools, both Rutgers Medical School, and he's serving as the interim dean of Robert Wood Johnson Medical School as well. Shortly, Dr. Naveen Balam will be sharing with you an introduction for Dr. Johnson. And prior to that, I just want to make sure that everyone is comfortable in our virtual room right now and that you have all of the accesses you need for the best viewing experience. So I just want to first mention, if you are here and looking for CME certification as a result of this session, please just email me after the session. My email address is up on the screen. I'll also put it in the chat. And I will be forwarding to you a certificate of completion for attendance here today. And I will also forward to you your certificate, as well as I will submit those CMEs for you. And just one final note, when I close this sharing screen, you'll notice at the top of your view, you'll see options for viewing. There's a few different tile options. And as there are many of us joining today to hear from Dr. Johnson and Dr. Balam, so that you're not distracted by all of the various profiles of the audience, you can choose the center tile to make sure that you're only viewing the speakers. So that's a more optimized viewing experience. Also, feel free throughout the course of the session to put your questions in the chat. Towards the end, there will be a Q&A, and if you would like to ask the question yourself, you're more than welcome to do so. In the chat next to your name, there's a little hand, and if you click that hand, that's your virtual hand raise, and I will certainly unmute you so that you can ask your questions directly. But feel free to submit them through the chat if you prefer that I submit those questions on your behalf, and I'm happy to do it. Okay, so without further ado, I first would like to introduce you to our president and CEO, Dr. Mary Ellen Klein, who has been extremely supportive of all of our efforts in our journey towards diversity and inclusion and to address disparities in healthcare outcomes. And she has a few words of welcome for you prior to the commencement of our program today. Dr. Klein? Oh, you just have to unmute Dr. Klein. Oh, there you go. You're unmuted.
Thank you so much, Desiree, and I would like to welcome all that are here with us today virtually. I know that today's topic is so very, very important. From the perspective of Clara Maass, when the hospital came to be, it was truly established so that every member of the community would be served as they should, and with the highest level of compassionate care. Part of that component of having inclusive care being part of our own DNA is that we always want to be able to meet the very rich needs of our diverse community. Collectively, as a hospital and a healthcare system, we also understand that being inclusive requires more than just good intentions and compassion to deliver the highest quality, competent care, but we want to understand that it is foremost, we have to address the social determinants of health, which can create the systemic barriers for those who we serve in our Black and Brown communities. Our very own President and Chief Executive Officer, Barry Ostrowski, has taken this to the highest level for us as he has adopted an anti-racist organizational mandate. He has created a racial justice subcommittee of the board for our system, and we have prioritized how we can look to dismantle racism through his steering committee that he had formed, and looking at how we together can pursue equitable health outcomes for those we serve. To that end, we must address and eradicate the inequities in healthcare. With that, we are so very pleased that Dr. Johnson was able to be here with us today to provide his insight, his experience and wisdom to help us along our journey. And on behalf of the entire Clara Maass Medical Center family, we do want to thank you, Dr. Johnson, so much for being with us today. And also, I would be remiss if I did not thank Desiree and also Dr. Ballum for putting the program together and guiding us through the program today. Thank you so very much, and we look forward to the remarks.
Thank you so much, Mary Ellen. Next, I'd like to introduce to you our interim chief medical officer, as well as our chief clinical effectiveness officer and the medical director of bariatric services at Clara Maass Medical Center, Dr. Naveen Ballum.
Thank you, Desiree, and thank you, Mary Ellen. It's with extreme pleasure I'm going to introduce to you Dr. Johnson, our outstanding speaker today. It was 52 years ago that Dr. Johnson joined New Jersey Medical School, first as a student, graduating in 1972, completing a residency in pediatrics at the medical school, followed by a fellowship in adolescent medicine at NYU Bellevue. After he completed that training, he returned back to be the chair of pediatrics and start a adolescent and young adult medicine program at the New Jersey Medical School. Over the span of a long and extraordinary career, Dr. Johnson has passionately devoted himself to the mission and values of the New Jersey Medical School. He assumed leadership roles very early on. In 2011, following a 7-year tenure as interim dean, Dr. Johnson was named the Sharon Joseph L. Muscarell Endowed Dean of the New Jersey Medical School. Dr. Johnson's clinical expertise and research focuses on adolescent physical and mental health, adolescent HIV, adolescent violence and sexuality, health equity, and family strengthening. He is a well-recognized spokesperson for the adolescent and adolescent issues. He regularly addresses many local, state, national, and international audiences on these issues. Throughout his career, Dr. Johnson has long been a champion of those who are marginalized in medicine, treating AIDS patients in the early days when there's a paranoia and hysteria in reaction to those diagnosed, advocating for the LGBTQ community and for people of color. Even while serving as the dean of 2 medical schools, Dr. Johnson continues his clinical practice at the New Jersey Medical School, for which says it has provided him some of his most satisfying moments in his career. On a personal note, Dr. Johnson somehow finds time to fulfill his personal passions. He serves as a deacon at Union Baptist Church in Orange and serves as a member of the Board of Deacons. And amidst all of this, having sifted through his 86-page resume, he finds time to publish not only articles, but write books. He's published 2 books, one called The Race Trap, Smart Strategies for Effective Racial Communication in Business and in Life. And then the second book is titled Strength for Their Journey, 5 Essential Disciplines African-American Parents Must Teach Their Children and Teens. So an incredibly accomplished person, and it's an honor to be able to really hear from Dr. Johnson today about health inequities and the social determinants of health that are affecting our communities. Like Dr. Barry Ostrowski and Mary Ellen so eloquently put, we are a hospital not only for the community, but really of the community. And these issues are of utmost importance. So to get right into the questions, first of all, Dr. Johnson, thank you for being here and part of this talk. Would you like to make any comments before I begin with the first question?
Well, thank you all for inviting me this afternoon. I'm very impressed that there are 77 people on this call already, and it just goes to show how important these issues are. I think for the sake of full disclosure, one thing that you didn't mention, Dr. Ballum, is that I'm a member of the board of Barnabas Health System. And so this is within the family. And I, too, am very impressed that Barry has taken this on. I dare say there are not many other healthcare systems that have recognized the importance of race and racism to the achievement of what is in front of us. So I'm very happy to do this and happy to share whatever I can from the experiences I've had over half a century, which seems like a long time, but doesn't feel that way.
That's great. So Dr. Johnson, what do you see as the most impactful social determinants of health impacting Black and Brown communities today in New Jersey?
If you look at a list of all the social determinants of health, you'll see a long list of things that go all the way from education to poverty to neighborhoods to availability of food to health insurance, and a whole list of things. And within that is the word racism. And if you think about all the different things that contribute to adverse outcomes in healthcare, in every one of them, you can whittle it down to considerations of race. There's a new book out called Caste by Isabel Wilkerson, and it's about the caste system in India, the creation of the caste system in Germany, and the caste system in the United States that actually is related to slavery and the impact of race over the history of our country. And it's very telling. So that at the bottom of everything is race, and the way race is appreciated, the way people react to race. And so we all need to understand how we react to race as an issue. And after we understand how we personally react to it, then we can begin to develop a response to the problems that that result in the adverse outcome. So to answer your question, I think the bottom, at the foundation of the issues, it's really race. And one of the other reasons why it's so important that within our family, we are taking this on as an issue.
Excellent. What biases and stereotypes tend to be at the root of disparate treatment of Blacks and Brown patients that we see, whether it's interpretation of pain management needs, beliefs in commitment to treat or follow through with behavior modification or treatment regimens? What do you find as the root of this disparate treatment?
You mentioned that one of the books I wrote was a book called The Race Trap. It was written for businesses back in the 1990s. And one of the themes in that book is some research that we did about how each of us perceives ourselves and things like us or people like us and how we perceive others. So if you just think about it, think personally now, what you are most comfortable with is the environment where you were born, where you were raised, the family, the community, and all that. And in your head, that's what you see as normal, right? So as you approach someone that is from a different environment or a different race or a different set of circumstances, you see that intuitively as being different, or in some cases, abnormal. And that leads us to begin to think about or to make mistakes in the way we approach other people. Because we think, well, this person who is different than me is not approaching things the same way I approach things, then that's something wrong or abnormal. And so the basis, so that what happens as a result of all that is we begin to make other assumptions we call stereotypes. For example, the assumption that someone who is Black or brown has a different sense of pain and may not need as many pain medications, or that someone who is from a different environment is probably going to be non-compliant, and we just assume that's going to occur, or that someone has a different probability of acquiring a certain disease than someone else from that. So all of these little things come up in our head. Now, today we call that unconscious bias. We just operate on these things and based on these intuitive feelings within us, and we make these assumptions about other people. Now, what's important for all of us to do is to understand that we all have unconscious biases and prepare ourselves whenever we're approaching someone who's different than we are, and begin to ask ourselves, are we correct in the assumptions we're making? Is there good evidence for the belief that this person sitting in front of us who is different than us is going to react differently or react the way I think they may react? Now, none of us wants to think of ourselves as being racist or biased, but these mechanisms operate within us. And in order for us to prevent making some big mistakes, we have to begin to ask these things in every encounter that we have.
Yeah, that's excellent. Thank you. How can culturally competent care be delivered in our institutions to diverse patients and vulnerable communities such that this sensitivity translates into improved health outcomes?
Well, one of the most important ways to improve cultural competence in healthcare is to make sure that that healthcare is culturally diverse. So the more diverse the providers of care, the better the care is ultimately. Now, that's a tall order because among physicians, the diversity is not good at all. And it's going to take a long time before we become as diverse as we need to be, or for the diversity of the healthcare providing community to reflect the diversity of the community that receives healthcare. The other thing that's important is for us to be trained in diverse environments. So as we train in diverse environments, we begin to adopt and learn or begin to understand some of the biases that we may have and begin to mitigate some of them. However, those are the long-term effects. The other thing that we need to do is what we're doing today. We need to take this on and sit down and think about ourselves and understand that the adverse outcomes that we have in communities like Newark or other communities around the country are a result of racism within healthcare. And if we're going to begin to mitigate that, then we have to say, yes, this is occurring. And if we're going to resolve the problem, we're going to have to solve it ourselves by taking it on. So it's, in many ways, it's an easier thing because it's something we have to do ourselves. In other ways, it's a very difficult thing because it really causes us to answer some very difficult questions. And no one likes to think that they're doing anything that's wrong, but we do it all the time. You can see it. Now, the other thing that's important is that if we become sensitive to the way in which bias operates, then we also have to speak up about it. And so, for example, just think about how often you think that this Black person you're seeing is articulate. And you've probably heard it. Now, if you see a young Black person who speaks English well, you say, "Man, that's an articulate person." But you know, that's a racist statement. It's a racist statement because the underlying assumption is that because this person is Black, they would not be articulate. Now, that becomes a shock to many people, but that's what it is. Or if you think that you don't have a racist bone in your body, that you don't see race, that's also a racist statement because we all see race. We don't want I don't want anyone to look at me and say, "Oh, I don't see that Dr. Johnson is Black." Of course you do. And that has an impact on you. And in order to really operate with and to counter the impact of race, we have to begin to see. So those are just a few things, but it's not, it requires us to take it on and take it on in a major way.
Yeah, no, I think that's excellent. The challenge is this is something we have to have a short-term solution as well as a long-term plan. And I think being part of the medical school and creating the future of the students and the healthcare leaders of the next generation is going to help us in the long term kind of address some of these biases and issues. Mm-hmm. For the next question, it really goes around the children that are starting medical schools. How are medical students today being prepared to deliver culturally competent care? Are students being taught about systemic racism and social determinants of health? And how is this being incorporated into their curriculum? When I went to medical school, we were just taught about the science of healthcare delivery, and mm-hmm. these weren't really core competencies of a medical education. How has that evolved?
Well, we know an awful lot more about the social determinants and how they affect health outcomes and disparity in health outcomes. And that's something that we are becoming more and more aware of as time goes on. So that is now in the curriculum. It is a significant part of the curriculum at both New Jersey Medical School and Robert Wood Johnson. I actually give the lectures, one of the lectures in that. And to to fight against disparities in healthcare, they have to understand something about the social determinants of health, and more than that, understand how they have to face it. Now, let me make it really clear that the solution to all the determinants is not solely in healthcare. There's a big piece of it that's in healthcare and a big piece of it that we own, but there's a larger piece, a larger social piece. So, and this is some of the research that I've actually been personally involved in at the CDC, that the most important corrective action we can employ is education. And so early childhood education, good educational systems will eventually result in improvements in the social determinants. Getting jobs will do that. Changing the communities will do that. So there are lots of things that are not wholly owned by the healthcare system, but there are big pieces that are within the receipt of healthcare that we have to understand and adopt. And so that's part of the curriculum that we have now. The other thing is that we seek to have students in a educational environment that's diverse. So we seek to have diversity in the student population, seek to have diversity within the faculty, and we seek to make sure that students learn from patients and learn from diverse patients. So it's a major part of all that we do. Now, this is going on in all medical schools throughout the country. We understand this is really critical to healthcare, and the young people who are in medical school today are encountering a curriculum that is much richer in these issues than they have in the past.
That's great. One of the things that's near and dear to my heart is the social determinants of health around obesity. And to your point, we see that access, food deserts, etc., are very different, and those kinds of issues really need to be addressed by policy. So it's a combination of what we do in our institution, the piece on education, and then policy. And I think that's what we had when we had our talk with Barry Ostrowski. He, at a system level, they were really focusing on policy changes to help with not only the social determinants, but some of these inequities that exist.
Yeah.
What is your vision to impact change locally for vulnerable communities of color?
Well, I'm a pediatrician, and so I think of everything in terms of children, and I think of everything in the long term. And my vision is to improve the education in our city, in the city of Newark. That starts with early childhood education, and to the extent that we can get children into preschool, I know all our data is consistent in this, they end up having better outcomes. It also starts with better elementary schools and better high schools. It also starts with more students going to college. One of the initiatives that I'm involved in is an initiative to significantly increase the number of individuals in the city of Newark who graduate from high school or graduate from college. Now, we know, and we have good data on this, that educational initiative will decrease violence in our city. It will decrease drug use in our city. It will also increase employment in our city. So that's my long-term goal, and that's what I'd like to see happen in a population sense. I do still treat teenagers and young adults, and so I would like to see a number of very important things going on in their lives too that are related to some of these. You can't think about this, however, without thinking about what's going on right now. The educational system is adversely affected by COVID-19, and the ways in which the socialization systems are adversely affected by it. And so, and my belief is that we need to get back to where we were a year ago. And I think the way we're going to get back to where we were a year ago is to make sure that 70% of the population is immunized. So my short-term goal right now is to get a vaccine. Fortunately, we're working on 2 of those at our medical school, and we need to begin in January vaccinating as many people as possible so we can return to where we were.
What is Rutgers Medical School doing to diversify its leadership, teachers, and students of color? Because as you mentioned earlier, to have diversity and a diverse education really enriches the quality of education and helps address some of these issues.
Well, our ability to diversify the student body is a function of diversity at the college level, because that's where people come from. And then diversity at the college level is a function of what happens with young people moving from high school into college. And so, although we know we can't have a direct effect on that, we can, however, begin to increase the number of students in our community who are interested in STEM careers, interested in health careers. And so for years, we've had programs that we call pipeline programs that bring young people from our communities into the medical school, begin to get them interested in health careers. In addition to that, provide them with types of additional educational support that will allow them to get into college and then go on from there to medical school. So we've been doing this for a long time, more than 25 years, and we have had a number of examples of young people who've gone through these programs and have gone to medical school. Some in our medical schools, some in other medical schools throughout the country, some in other health careers. And so that's one of the things we can do. It's a small, given that we're just 1 or now 2 schools, and it's not a whole lot of people, but it is something we can do directly. So that's one thing. The other thing that we can do is to try to recruit as diverse a faculty as we can. And so every search that we have has a requirement to make sure that when they're looking for a new chair or a new faculty member, to make sure that we make a very strong effort to recruit minority or underrepresented minority faculty. And we actually have done a relatively good job of that. We are known as one of the most diverse schools in the country. That doesn't mean we have high numbers, but we have numbers that are larger than most other schools. So that's what we are doing. But it takes all schools, all 150 medical schools doing the same thing. It takes all the colleges and universities doing the same thing to really begin to make a difference. But that is going on.
What can we do as care providers, as a hospital and an organization to aggressively address ethnic and cultural barriers impacting racial differences in health outcomes? We talked about, the top-down approach from what we're seeing as a system and in the medical schools, but for the frontline workers and people in the organization, what can we do to impact change?
Well, it's an inside-out approach. Each of us has to understand that we're part of the problem, and we have to make a commitment we're going to do something about it. And so the fact that there are now 82 people on this call is wonderful, on this web thing is wonderful. And it means that as an institution, we are addressing it, and we're all making a commitment to it. So that is the single most important thing, that everybody adopts this as a personal commitment. Once we adopt it as a personal commitment, then the changes begin to occur. Because then, as we begin to make administrative decisions, make policy decisions, make decisions about healthcare protocols, every one of the things is affected by our own personal new view of the way in which we have to approach race. One of the problems that we have with so many things in our society is we look to see what everyone else can do about solving it, rather than what we can do about solving it. And we have to accept this as our own issue. And once we own the issue, then it gets better, much more effectively than it would if we set up someone else or another group of people to take it on as an issue.
how can we attract and retain physicians, nurses, employees who reflect this diversity or this change that will be our agents of change?
Well, if we make it clear that that's what we're all about, that is something that is important for our institution. Now, here in this call, you have the CEO of the hospital and all the people in the system who say, this is what we're going to do. We have to say it very loudly, and we make it clear to anyone that if you don't understand that this is what we're all about, you shouldn't work here. You shouldn't be part of us. So every one of the interviews you have, the literature that we have, every approach that we have to new people coming in to understand that this is what we're doing. So that's how we do it, a total approach throughout the system. And we are doing that from the top all the way down.
No, that's great. So that wraps up the questions I have here. One of the things I wanted to add was, I mentioned that when I was in medical school, social determinants wasn't really a focus, and I'm glad that change has occurred. I'm currently getting a master's, and that has enabled me to take a class on social determinants. Mm-hmm. One of the first things I had learned in school was it wasn't about us. As physicians, we sometimes feel like we're the center of the world, and then the focus is redistributed to the organization. Mm-hmm. So then in school, I learned it's not about us, but it's about the organization. After listening to you today and Mary Ellen regularly and Barry when he came and met with us a few weeks ago, I realized it's not even about the organization, it's about the communities that we serve. Mm-hmm. And I think that when you start looking at it from that lens and appreciating that, I think that can really help us drive to address all these determinants that we face on a daily basis that we don't even recognize. Mm-hmm. So it's that change in lens. So I want to thank you for answering the questions that I posed. Desiree, are there any questions from the audience that we'd like to take at this point?
Yes, Dr. Bellum, there are. So Dr. Johnson, one of the questions is, do you think the super digital divide will further cause health disparities among communities of color? We now see how important digital access is for delivery of care, but where does that leave the most vulnerable?
Yeah, it's a major issue, and we're seeing it also in education because with education going to digital approaches, we're finding that in many communities, young people don't have computers, or don't have connectivity, or they don't have the types of knowledge that they need in order to use it. So that is a problem. I think one of the things we need to do is to make sure that as a function of government, we should make all digital access available to everyone because it is such an important factor. As we go to telehealth and we more increasingly use these types of methods to deliver healthcare, it's going to be a problem. And so yes, it will be a factor that can increase the disparity because right now in our country, there is a direct relationship between your income and your ability to use digital methods. And that's like not right today is like not being able to read. And so it is something we have to take on. But this is I think it should be a function of government because it is the thing that's going to put everything on a level playing field.
Thank you. Yes. Another question, Dr. Johnson, is what is your opinion regarding the NAM's recommendation that the COVID-19 vaccine is prioritized among African Americans and Hispanics, even though these groups were notably underrepresented in vaccine trials?
Well, a couple of things here. One is that underrepresented minorities need to be in vaccine trials, and the vaccine trials we're doing in Newark is filling that gap. And I can't tell you the exact number, but it is one that was focused specifically to underrepresented minorities. One of the reasons we need to do that is to make sure that the vaccines are safe and effective in underrepresented minority populations. The the decision about how to distribute the vaccine is something that should be made by a rational governmental entity. And we should have been talking about or developing a way of getting vaccines out back in May and April, when we knew that was what we were going to need. And we need to build a national trust in vaccines. The latest we know is that we need to achieve levels of 70 to 80% vaccination adoption in order to significantly decrease transmission in communities. And we need to make sure that that adoption occurs in groups that are vulnerable. So in the elderly and in underrepresented minority populations, and also within healthcare workers. So that's what we need to do. But remember, I predicated this by saying we needed to have a governmental entity that has taken on this fight. Now, that same governmental entity could have made sure that we follow good public health measures, like wearing a mask and social distancing. But that didn't happen either. So I promise that's the only thing I'll say about that issue.
I see a lot of nodding and in agreement, so point taken.
Yeah.
Another question, Dr. Johnson, is our communities tend to distrust the medical field, specifically immunizations, which you just spoke about. When we think about the Tuskegee study and the story of Henrietta Lacks, how can we help our communities see the importance of immunizations while still validating their feelings about the history of mistrust?
Well, one of the things we have to know is we need to know that history. And Isabel Wilkerson's book goes through that in extensively. And so I'd suggest everyone read that because slaves were used in medical experiments by female slaves were used by Sims in developing one of the techniques in obstetrics and gynecology. The Tuskegee study was one where we learned about syphilis as a result of not treating African-American men who had syphilis. Henrietta Lacks was the HLA antibodies came from her, and we didn't know, and the family was never recognized. There's an over and over again, and so African Americans in particular were misused and abused in healthcare. That is fact. And it's not only in healthcare, but almost everything. So we have to own that. This is what happened. And it is no surprise at all that it's understandable that people in Black and brown communities would mistrust the system that has this type of history. So that's fact as well. But then the other side of it is we need to provide the type of healthcare we need. So some of you may know that when we began to do the vaccine trials in Newark, there were demonstrations opposing it. We had to spend a lot of time talking to the mayor and the city council about the vaccine trials while we were doing it. And so the way I think we should approach this is we as a healthcare community need to continue to say, this is what needs to occur. We need to continue to make sure that we communicate and be completely transparent with communities, and we need to understand that the reactions that people have over time. So, but the thing that we should avoid doing is to blame the communities for not participating. Say this is wrong because they don't accept what we want them to do. It is understandable that they don't understand it. And we need to spend the time that's necessary to go over the explanations, to explain everything and to make sure that everybody understands it. It's a little frustrating, but there's just no other way to do it, and that's the way we have to approach it, because we cannot deny the history. We have to accept the history, and we have to overcome the legacy of that history.
Absolutely. Thank you. Are there any questions in which someone would like to be unmuted to ask directly to Dr. Johnson? If you
Dr. Johnson, can you comment on the latest COVID pandemic and how that's impacted Black and Brown communities? Because, we talked about the Tuskegee trials and the inequities that existed, a long time ago, but today we're still seeing continued issues and poorer outcomes based on your zip codes. So what is your opinion about what's happening with COVID?
Well, the excess death and morbidity is a direct result of the social determinants. We've seen it directly played out. Poor access to healthcare, poor increased levels of underlying conditions in your area, the obesity and relationship to diabetes type 2, all of these things make the outcomes worse. And so if you are underrepresented minority, if you acquire COVID-19, you're likely to have a worse outcome. You're likely to not be able to get into healthcare as quickly or have as easy access to healthcare. In addition to that, when it comes to the public health measures, what we said to people was that you should take furloughs and you should stay at home. But in our communities, more people couldn't do that. They were in jobs where they had to go out, so they were worked in sanitation or transportation or even some of the healthcare areas, and so they weren't able to equally participate in the public health measures. And then, on top of everything else, there was the economic factor that you were less likely to have the economic reserves you needed to continue to feed your family or to continue to provide shelter. So this was a perfect example of the impact of health disparities. And any pandemic or any major epidemic has the same effect. So if you look at flu, for example, same thing. You get much worse impact on underrepresented minority communities because of all the health disparities. So that's been a major one. The one thing that I think needs to be commented on is the juxtaposition of the Black Lives Matter movement and the COVID-19 pandemic. I am sure there's a relationship, and I don't know. I think it's going to take some time before we can get beyond this and see what the relationship is. But there is a relationship there, and there are going to probably be a lot of legacies of this time, and that's if positive change occurs as a result of all this, that will be one of the legacies we can look back on. And everything. And if you look in history, these major health events have had long-term effects. HIV has changed the way in which we approach healthcare. The Spanish flu over 100 years ago changed many things, and so that's what we will know some time from now when we begin to look back on what's happening.
We have another question, Dr. Johnson. What are some of the things that we can do as community leaders and good neighbors in our community to convey the importance of safety, wearing masks and physical distancing, given that as a culture, we really love opportunities to gather and connect, especially during the holidays?
Yeah. Oh, okay. So leaders need to lead by example. And so leaders should always be masked. Leaders should wash their hands. Leaders should socially distance. And I said I wouldn't say anything about politics, but that leadership, again, starts at the top doing all these things. So that's one of the things. The issue about the holidays is a really difficult one because if there was any time we needed the love and the comfort of family, it is now. The wonderful spirit that happens over Thanksgiving and the holidays in December is very important to all of us. However, this year we can't do that. We can't travel outside of our communities unless it's going someplace where there's less infection than we have here in New Jersey. We can't have large gatherings in our home because we run the risk of spreading infection. So as leaders, we need to emphasize that and do it ourselves. So that's a very important thing to do. It is still here. It is getting worse, and we can't move away from it and just say, well, maybe I can just take a chance. You can't take a chance. You really do need to make sure to do all the things that are needed in order to decrease infection.
Another question is, can you discuss the word compliance when referring to patient behavior? More specifically, the use of this word in medicine that seems to dismiss the underlying cause of non-compliance.
Well, I think it's, compliance simply means that you're following the recommendations of the doctor. I think the issue is that we always have to ask ourselves, why are our patients not following the recommendations? I think that's a more important thing. And my view of it is it's always us. We have either not explained or what's important, or our patients have not gotten enough information to adopt it themselves. And so I think it's important for the doctor to establish, the healthcare provider to establish the patients are following the recommendations. But if they are not, then the doctor needs to accept ownership for the fact the patient is not following those recommendations, and then we need to work with the patient in order to do that. So I don't think compliance is a bad word. It becomes, or non-compliance becomes a bad word when it's used to blame the patient, and it's not the patient who's at fault. It is the provider who's at fault. And if you think about achieving something, it's a much more powerful position for us as providers to accept the responsibility ourselves, because then we can do something about it and to work with the patient in order to help them achieve. So whenever I face that, I understand. I said, well, let's talk about what happened and why you're not taking the medication the way you want to. And it takes a while for us to do that, but because we don't think enough about what we're requiring people to do and how that fits into someone's life. I mean, back in the early days of HIV, we were asking people to take 15 pills a day, and we just write out a prescription and give it to them and say, well, take those pills a day, without thinking about, well, how does someone really do that? What effect does it have on your daily life? How do you modify your schedule? And those types of things need to be considered. We need to understand how people fit these things. So when you become old enough and you have to take a lot of pills, then you begin to understand that much better.
Okay, another question is, could you comment on the hiring challenges surrounding recreational and even medicinal marijuana use? Interesting question.
Well, it's an interesting question. I think it's one that's going to be serious. It's quite possible that on Tuesday, marijuana will become legal in the state of New Jersey, and we're going to have to decide whether or not drug screening is a legitimate part of what we do. Now, I think from the standpoint of healthcare, we require our employees to be of a sound mind whenever they're involved in healthcare. And so, the way I look at it is that the same alcohol and marijuana are the same thing when it comes to whether or not you could be impaired. So impairment is not something that can occur, that you can tolerate. The problem with marijuana is, however, that the test that we do has a longer timeline, a length of time positivity in the test than does alcohol. And so the positive test, a drug screen with marijuana in it, does not necessarily mean impairment. And we're going to have to figure out how we're going to, what we're going to do about that. So, so that's one of the things. I don't know what other, the legislature, assuming that that it's passed, the legislature does have to make up some rules about ages and things like that. But those are the thoughts I have right away. I have actually been thinking about that, and then what is the impact on employment, and we just have to make some decisions.
Dr. Johnson, there are many people on the call that are frontline healthcare, RNs, physicians, diversity leaders. What are a couple things that you would hope that we would walk away from this session knowing and doing differently as a result?
Well, one of the things I've said over and over again is the introspection, that we would all think about ourselves and how we view anyone who's different than us, and think about how we fall into the stereotype traps and how we fall into the unconscious bias traps, and make sure that we guard ourselves against doing that. The other thing is that I would hope that we would at least begin to think about approaching other people when we see them fall into that trap themselves. Sometimes it's a little bit safer not to say anything, but we need to speak up. And as we speak up and make it clear that that these statements, these attitudes are not acceptable in our environment, we're not going to tolerate them. And if we don't do that, then that will more quickly set the tone in our work environment and our communities that will be better and healthier for all of us.
Yes, so true. We, part of our values, their safety values, the S stands for Speak Up for Safety. And we just recently, last week, had a discussion with all of our leaders around bias being a key thing that we should be speaking up when we identify. So exactly as you say, Dr. Johnson, just as we would speak up if we saw a patient that was at risk of falling or being harmed, we should just be as assertive with speaking up if we see bias entering into the treatment or care of a patient. Another question, in our area, are there any stats that you can share about how the COVID-19 vaccine has performed in African American and Latinos?
We don't know yet. The one thing we do know is we know that it tends to produce good responses in the elderly. We don't have enough information yet about, at least, and this is really just the Moderna trial. We don't have enough information yet about the difference in underrepresented minority populations. Now, having said all that, remember the rate at which we have began to accumulate and attack this is astounding. Remember, this whole thing has been with us for 9 months, and developing the vaccine and acquiring the approaches we've acquired in such a very short period of time is really remarkable. So it'll be a while before we actually know all the answers, but it's a testament to the science throughout the world that we are where we are right now. The failing in the COVID pandemic has been a public health failure, and the public health failure is not because the public health community hasn't told us what to do. It's that we have not had the leadership throughout the country that adopts sound public health approaches. And I did say I would make any more public political comments.
We'll consolidate them into just one statement. Before any closing remarks, does anyone else have any questions that they would like to pose to Dr. Johnson as we prepare to close?
Can I speak up?
Certainly, please do.
Dr. Johnson, Dr. Ortiz here. I just wanted to say I'm glad I joined the call today because, you've been a mentor of mine since the days I started medical school when I was in United Hospital at the adolescent rotation. And you really showed us what patient-centered care was all about way back then, and about, the need of leadership to be consistent, persistent, based in fact and data, and spoken about. And you've been that mentor for me. And I've taken on most of the things that you just spoke about today in my own practice and my own leadership role, and I appreciate that very much. I want to thank you for that.
Well, thank you. It's great to hear. I've been around for a very long time, and over that time, I've had the opportunity to work with many people who have gone into various healthcare careers. And one of the most rewarding things in my career has been the ability to have that impact on people, and it's really very, very rewarding. Thank you all very much.
Are there any other comments before we close?
Thank you.
Crystal, did you have a question?
No, I didn't. I just wanted to say thank you. I was so excited when I saw that that this managed to be planned, because Desiree and I had spoken about you in other contexts. So I just want to tell you that I have Cast at home. I'm in the process of reading it. It was gifted to me. I think you did say another book. Was it called Skepticism?
Well, her other book was about the migration of African Americans from the South to the North. That was also very good. But Caste is the book that.
Okay, that's the one. That's the one that I have now.
This book is very, very good. Yeah.
Yeah.
Thank you, Crystal. Anyone else? I don't want to leave anyone out before we close. If there are any other comments or thoughts.
Just again, thank you so very much. We're truly blessed to have you here with us today for the program. Thank you so much, Dr. Johnson.
Oh, I want to thank all of you. This has really been energizing. I had no idea what I was going to say before we start this, but this has been very good. I've enjoyed it. Enjoyed this hour.
Well, we were thrilled to have you, and I think we'll all walk away changed from what we've learned from you today, and carry with us all of your guidance and thoughts and experience with us. And we thank you so much for just agreeing to be here and for all that you've brought to us.
You're welcome.
Thank you so much. And thank you everyone for joining. I will be emailing a survey link following the session. If you could please get back to us on that, and feel free again to email me should you need CME credits for your attendance today. Thank you so much, Dr. Johnson. Thank you, Dr. Klein. Thank you, Dr. Ballum, and all of the attendees for being with us today. Enjoy the
Thanks,
rest of your
Dr.
day.
Ballum. Thanks,
Thank
Mary
you.
Ellen.
Thank you.
Thank you.